Good afternoon. We welcome everyone to the first CPC of this year. Today's discussant is Dr. Apul Goel. Sir is Professor and Head at Department of Urology at King George Medical University, Lucknow. Sir has wide experience and skill in urologic oncology, endourology, and surgical procedures. He is current editor-in-chief of Indian Journal of Urology. He was member of editorial board International Journal of Urology, the official journal of Japanese Urological Association, and the official journal of Urological Association of Asia. Sir is a co-author of various books and has published various chapters and articles in journal of national and international repute. Sir is also WHO expert for lymphatic filariasis, and also he has a patent in his name. AIIMS New Delhi welcome you, sir. The dice is all yours to discuss the case.
Good afternoon, and thank you for the invitation, Professor Seth, Dr. Achal. So, I'll be discussing a case scenario that was given to me. So, this story is still last year, whatever has been sent. So, in August 2023, this 25-year-old man, 45-year-old man developed painless gross hematuria associated with clots. The hematuria was intermittent and complete because it's a heterogeneous group. So we typically look for whether the hematuria is initial, terminal, or total. So here it is total. So that means the lesion may be in the urinary bladder or above. There is no history of dysuria, lithuria, obstructive lower urinary tract symptoms, or flank pain. So once the patient comes to us with hematuria, we like to localize the site. For that, the two common sites from which a patient can come with hematuria is the kidneys and the urinary bladder. So to localize, we ask for history of flank pain, so that we come to know whether the origin is from the flanks, the kidneys, or whether the source of hematuria is from the lower urinary tract, that means the bladder. So we ask for symptoms like dysuria, obstructive or irritative voiding symptoms. This irritative voiding symptoms was not given to me. So I'm not aware whether the patient had storage symptoms, which means frequency, urgency, or nocturia. There is no history of loss of appetite or weight loss. So chronic illness or malignancy, you can say, but chronic illness. So it doesn't seem to be chronic illness. There is no history because the patient comes to us with hematuria. So there is no history of bleeding disorders or history of anticoagulation that we typically ask in patients who come with bleeding. There is no history of diabetes, hypertension, or tuberculosis. The patient is non-smoker. Tobacco intake is a risk factor for bladder tumor. So this is what we typically ask in such patients. So this is the past history of this patient. So when he was 9 years old, so he had presented to the same hospital, All India Institute, and was diagnosed as having post-traumatic urethral stricture at the age of 9 years. At that time, he underwent two-stage repair and was advised intermittent catheterization. This is not the typical term that we use. Self-calibration is probably a better word. And was doing this procedure probably once a day since then, since 1990. That means 35 years. So subsequently, he noticed a gradual and a progressive decline in urinary stream. That was in 2018, for which he underwent endodilatation. Endodilatation is cystoscopic dilatation. So it's assumed that maybe the person who has done this cystoscopy has seen the urinary bladder. Maybe it was done in cystoscopy at that time. Maybe there was no tumor there. And post endodilatation, he voided satisfactorily and has been well since then. So this is what we have in the past history. So there are certain details which are not known, and I have already mentioned storage symptoms, for example, frequency, urgency, because these symptoms are associated with bladder tumor. Or if we are thinking of inflammatory etiology like tuberculosis, then again you have these symptoms. Okay, so what I don't have is urethrogram, but my impression, because it was a two-stage urethroplasty, so must have been an anterior urethral stricture. Two-stage urethroplasty is usually needed for long segment strictures, but we don't have urethro. And because he was on clean the self calibration, so it's sort of a suboptimal result. And it's possible that in 2018, during the time of endodilatation, probably a cystoscopy was also done at that time, although we do not have any records. And this was 5 years back in 2018. So physical examination, general, everything is normal. Local examination is circumcised. Rest, everything is normal. So with this history and this clinical background, I like to keep, because hematuria, the most common reason being tumors. So there's nothing in the history I cannot localize whether it's coming from the bladder or the flanks or the kidneys. So I'll keep both the possibilities. Could be a bladder tumor, more common because it's more common. He's 45 years old. So again, he fits into bladder tumor and upper tract tumors, which can be a renal tumor, or it can be a transition, it can be a urothelial tumor from the upper tracts. It could be genitourinary tuberculosis. Long standing, he had a stricture at the age of 9 years, so 36 years now with a stricture and doing self calibration. So long term urethral stricture with suboptimal sort of results may lead to bladder dysfunctions. And at the time of doing catheterization, we are not sure how frequently was he doing self calibration, once a day or once in 2 days or once a week or something. So maybe bladder dysfunction, chronic retention, doing intermittent catheterization may cause decompression hematuria. And another possibility could be a bladder stone. So this is what is the clinical impression with this history. Evaluation, urea, creatinine, everything looks normal. Urine cytology report has been given to me, which shows inflammatory cells, no malignant cells. I do not have urine for AFB report or any other evaluation for tuberculosis. Culture report I don't have because sterile pyuria can suggest tuberculosis or malignancy. However, because he was doing self calibration, so the significance of culture is not much in this scenario, because these patients, because they are doing self calibration, which is not a sterile procedure, so they typically infect themselves. We don't have uroflowmetry report, which is done in patients with stricture urethra, and it tells us about bladder capacity because we are thinking in terms of tuberculosis, which leads to a small capacity bladder. So coming to the radiology, this is the ultrasound film, which shows some bit of hydronephrosis, which is mild. And you can see thickening in the urinary bladder on the lateral and the posterior walls. This is Doppler done, which shows maybe its vascularity and could be effluxing urinary jet from the ureter also. This is the CT scan films that we have. So you can see thickening of the urinary bladder. Typically, a urinary bladder tumor is more exophatic within the lumen. But it can be diffuse as well. A broad-based tumor can also be there with the urinary bladder. This is the rectum and this is the ureter. So MRI, MP MRI was also done, which again shows the findings similar to what we saw on the CT scan. We have diffuse posterior wall and lateral wall thickening, more on the right side. And like pyrads, we have virads for bladder masses, and it's a lesion 4. So likelihood to be muscle invasive. And the fat planes between the prostate, seminal vesicles, and the rectum are maintained. So now we have the history and the radiology. So we have to think in terms of hematuria associated with bladder lesions. So the kidneys are normal. So first of all, the first possibility would that be of bladder tumor, because flat lesions, as I said, are possible. Then there could be other lesions in the urinary bladder like cystitis glandularis. Could be infections because urine cytology showed inflammatory cells. These are could be bladder tuberculosis. It could be eosinophilic cystitis, interstitial cystitis, malakoplakia. Some rare tumors like lymphoma and there are certain inflammatory tumors, and then non-infectious lesions. There are large numbers. I have not listed all of them, but lymphangioma, ectopic prostate, even pheochromocytoma in the urinary bladder has been described. There are large number of malignancies. Okay, so because we have this history of stricture urethra in the past, so what comes to our mind, whether we can correlate his intermittent catheterization with this bladder lesion. So I could not find any paper that says that doing CIC for years can give rise to bladder tumor. But yes, we have data to say that long-term urinary bladder long-term indwelling catheters can give rise to squamous cell carcinoma of the urinary bladder because of chronic irritation. So, but CIC with bladder lesion, at least I could not find any article on that. So, in fact, there's no significant difference for T category. Spinal cord injury itself, this paper says that patients who have a spinal cord injury have a higher likelihood of developing bladder tumors. But this is, as I said, if they are on long-term catheters, there's increased risk of a squamous cell carcinoma. But they could not find, this is about a 7-year follow-up, they could not find whether the patient was voiding spontaneously or was doing CIC. For 7 years, there was no difference in the risk of developing bladder tumors. So CIC apparently doesn't cause bladder tumors. So that correlation doesn't seem to hold true in this particular patient. Whether a stricture urethra can give rise to bladder tumor, again, stricture urethra, because of causing bladder outlet obstruction, can cause thickening, hypertrophy of the urinary bladder. And this patient, essentially the findings are thickening, although it is not diffuse thickening. It's limited to the posterior wall and the lateral walls, but it's more like a thickening. So bladder wall thickness can be explained because of hypertrophy, because of bladder outlet obstruction, but it's not a generalized thickening. But yes, thickening can be explained by stricture urethra. But stricture urethra associated with bladder tumor, I could not find any cause relationship. Now, in my subsequent slides, I'll be touching upon the likely lesions that I think may be possible in this particular patient. As I said, cystitis cystica glandularis is a histopathological diagnosis, and some say that probably it's a precursor for carcinoma as well. So, and this may give rise to hematuria. So these are two separate papers, two separate images, two separate patients showing posterior wall thickening type of thing, which is a bit similar to what our patient has. So it's mostly located in the trigonal area, not the lateral wall. So that's a little different from this particular patient, but it can present with hematuria. Tuberculosis can have localized thickening. So this particular patient, tuberculosis, is a rare cause of hematuria, although hematuria is fairly common in patients with tuberculosis, genitourinary tuberculosis. Hematuria is fairly common, but it's mostly microscopic. Gross hematuria is a bit uncommon, and here what you have is isolated thickening of the urinary bladder. So hematuria, as I said, is fairly common as a presentation of genitourinary tuberculosis, but mostly it is microscopic and not gross. Tuberculosis, urinary bladder tuberculosis is typically secondary to renal tuberculosis because it's the AFB that is coming down from the kidneys that cause. So typically get, for example, in the previous patient, you have the kidneys are destroyed. So, but isolated tuberculosis of the urinary bladder without involvement of the kidneys has also been reported. Then interstitial cystitis and a variant of interstitial cystitis is eosinophilic cystitis. Almost similar, thickened urinary bladder. This is eosinophilic cystitis. Uh, Again, different report, similar type of thickening as was seen in the radiology of our patient. So fairly similar. Okay. Something happened here. So this, anyway. Uh, then another, lesion that can be a differential diagnosis in this particular patient can be malakoplakia, which can happen in other organs also, but genitourinary tract involvement is also seen. Usually associated with recurrent infections, especially with Klebsiella and E. coli. And you may have such type of lesions which resemble a bladder tumor. So CT scans show images simulating neoplastic infiltration and wall thickening, and similar things as is seen in our particular patient. Then you may have inflammatory tumors. For example, inflammatory myofibroblastic tumor of the urinary bladder. This CT belongs to a 36-year-old man. Again, with hematuria, similar type of CT with thickening and cystoscopy. This is a variant of inflammatory tumor. This is immunoglobulin G4 associated inflammatory pseudotumor of the urinary bladder, a variant of the previous slide that I shown. This patient has, a thickening on one side. So other possibility, lymphomas have also been described, which can be mucosa associated lymphoid tissue. Chronic inflammation is probably the underlying cause that leads to the development of this mucosa associated lymphoid tissue lymphoma. And this particular patient presented with hematuria and cystoscopy showed a growth. This is primary diffuse large B-cell lymphoma of the urinary bladder. So the CT scan is fairly similar to what our patient has. So again, hematuria associated with frequency dysuria, nocturia. We do not have this history, whether it was there or not in our particular patient. This is not known for our particular patient. So extranodal lymphomas are well described. Although primary urinary bladder lymphoma is very rare, secondary involvement of the urinary bladder by systemic lymphoma is much more common. Primary bladder lymphomas are uncommon. Other rare, I'll not discuss these. So my impression would be, because there's no bladder diverticulum, if we think in terms of thickening and long-term stricture urethra requiring self-calibration. So, but there's no evidence of bladder outlet obstruction in the form of bladder diverticulums or thing. Tuberculosis again is unlikely because the upper tracts are preserved. So, the CT scan and MRI is suggestive of a bladder mass. So, because we have evidence, his cytology showed inflammatory cells. So, we'll focus on bladder masses which are associated with infections or inflammations. So cystitis cystica glandularis is one, malakoplakia can be another. If we talk about malignancies, urothelial malignancies, the role of inflammation is there. So urothelial variants like adenocarcinoma, squamous cell carcinoma, eosinophilic cystitis can be a possibility, B-cell lymphoma, or inflammatory myofibroblastic tumor of the urinary bladder. So this is, although because we are surgeons, so we typically will just do a TURBT, which was done in this particular patient, and send the pathology to our pathology colleagues to telling us the answer. So, okay. Yes, yes, yes.
Uh, is there any way of knowing preoperatively whether we are looking at a malignancy or a non? These are the two broad categories that we look at: malignancy, urothelial, adenoma, squamous, whatever be the variants, versus the non-malignant, where the classical options would be either cystitis mystica, IgG4 disease, or leukoplakia. Is there anything that we can do pre-operatively without a TURBT, which would help us choose one between the other?
See, not there's nothing in this particular patient, at least to for clinically to suspect, you know. So maybe radiologically, maybe on MRI, but I could not find any data that can tell us whether we can differentiate inflammatory masses, the ones that I enumerated, with malignancy, the question that you are asking. So
Was the IgG level there?
no, IgG was not done.
So that would have been the only test I think which would have kind of thrown some light in favor or not of in favor of IgG4 or otherwise.
These diagnoses are typically made retrospectively. Once we do TURBT, send the specimen, it comes out to be IG4 tumors, and then we get a IgG test done and things like that.
Yes, there used to be ciprofloxacin scans, which are primarily for the renal tumors and for the bladder. You want to differentiate between inflammatory muscle versus abscess versus tumor. So, is there any role of those in the bladder? Like the question that you was asking.
No, I have no idea. But in fact, what you were saying, ciprofloxacin.
Ciprofloxacin labeled with nucleate.
Okay, okay, okay. Yes. Sure.
Maybe I missed out on it, I came a little late. But what was the reason you have explained for this partially functioning kidneys? 54%.
No. They are similar. I skipped that because the functions are almost equal. There's no reason actually. So typically we don't get a renal scan. I'm not sure this information is there intentionally because it was not helping in this particular patient. No. There are more questions.
Thank you, sir, for such a detailed and exhaustive discussion. Any thoughts or alternative diagnosis from the audience? Okay. Any questions for Professor Goel? Okay, now I invite the treating clinician how they worked up the case without revealing the final diagnosis.
I must congratulate Apul for an excellent discussion. This is what was expected of him, and I'm extremely happy that we invited him. And he has done full justice to the protocol that was given to him, and he has reviewed the literature very well. He brought out so many good slides, and in terms of pre-operative thinking, our thinking was to some extent similar, but perhaps not as accurate and not as detailed as Apul has indicated. We did think that this is like most probably an inflammatory lesion. He's a youngish man. He has been catheterizing himself for the last 35 years plus, and it looked like a diffuse disease. So the first diagnosis clinically that we thought, looking at the radiology, and one thing we were certain that it's not something minor, because a patient who has who's catheterizing himself can have some minor bleeds also. Just like while brushing teeth, one can have a minor bleed, but it was not minor. He had significant bleeding and he had multiple episodes, and ultrasonogram also showed something which was significant. So we advised him a CT scan, and that also corroborated whatever was seen on. So when we saw that there is a lesion which is practically infiltrating the wall, you can see on the CT scan there is a lack of distensibility of the right wall. So if there is a lack of distensibility of the urinary bladder on any of the imagings, whether it is full bladder CT scan or full bladder MRI, then that is suggestive of a transmural pathology. And transmural pathology is cystitis cystica glandularis, although it is mainly confined to the mucosa, but it can definitely go transmural. Again, eosinophilic cystitis is mainly confined to the mucosa, but again, it can go transmural also. Tuberculosis, it seemed very unlikely because if there is such an extensive bladder involvement, upper tracts being totally all right, and patient did not have any significant dysuria, frequency, etc., he was voiding reasonably well with self-dilation. So, these were our only thoughts, and the only plan. Now there is a cystoscopy video.
Video also. So I have it.
Yeah. So here you can see that these are reasonably well-defined nodular mounds. It is not like cystitis cystica is, it can have some solid material, but it has a good amount of fluid also within it. And that is more cystic, and therefore, so this is what, and it was diffuse. Although the main area of involvement on the CT scan looked right side, but even the left side was not spared. And frankly, on cystoscopy, we could not make any diagnosis. And malacoplakia, we have seen malacoplakia looks more like well-defined frondy. Malacoplakia is basically an abnormal reaction to bacterial infections where there are supposed to be different bacterial forms inside the L forms, etc., etc. So it's a, but that looks endoscopically that looks more like a bladder tumor, maybe slightly more necrotic, more friable. And similarly, amyloidosis also looks it more like a endophytic lesion, and after cystoscopy, after the biopsies, we had absolutely no clue what we are dealing with. So the only thing that we did was we rang up the pathologist, Dr. Seema, and we asked her to look into it from a different point of view and try to look into the literature and get all the possible studies and try to give us a diagnosis. We frankly had no clue what we are dealing with. So
Thank you, sir. Now I invite the radiologist for his inputs on imaging. Sir, please.
Not formally prepared anything. I just had a chance to review these images, and Dr. Goel said it all. You practically described everything. Upper tracts were preserved, and the differential function also, almost supported what we saw. And the bladder, as Dr. Seth said, was practically most walls relatively sparing of the left lateral wall in the superior and the dome. There was hardly any adenopathy. Asymmetric, didn't look like an obstructive disease because of the stricture. So it had to be something else. Frankly, you described all the differentials that one could possibly think, and actually more. So radiology-wise, statistically speaking, I would still would like to maintain that it would be a cancer unless it comes out something else, which pathologist knows the answer. Thank you.
Thank you, sir. We'll start with pathology discussion. So the first specimen we received was a urine specimen, and it showed some inflammatory cells and along with some benign urothelial cells, and it was reported as negative for malignancy. The second case, the second specimen was TURBT chips and deep muscle biopsy. The history was quite generous, which included urethral stricture and diffuse thickening of the bladder wall. And the biopsy comprises of certain bladder fragment. This is the urothelium, and in the lamina propria, we can see there is diffuse infiltration by some atypical lymphoid cells. And on another power, we can see there are some vague follicle formation here. And surrounding these are all these are atypical lymphoid cells. Still going on higher power, we can see these are all monomorphic looking atypical lymphoid cells. They are small in size, and there is no large cell transformation or there are no blastic transformation. There were no areas of necrosis. Still, we went ahead. We knew we are dealing with some atypical lymphoproliferative disorder. Still, we went ahead with the epithelial marker. Cytokeratin was negative and GATA3 was negative. Then we did the routine panel of CD320, in which CD3 was highlighting the background T cells and CD20 was diffusely positive. At this point of time, we were dealing with it is a non-Hodgkin lymphoma B cell. So how to work up a case of BNHL, indolent BNHL? It was an indolent lymphoma because they were small in size and there was no large cell transformation. So routinely we do CD5, CD23, cyclin D1, CD10, BCL6 and Ka67. Based on the positivity and negativity of certain markers, we are able to reach to a diagnosis of mantle cell lymphoma or a follicular lymphoma or a marginal zone lymphoma. So we went ahead with CD5 and CD23, which was negative, and ruling out the possibility of a mantle cell lymphoma. Then ruling out CD5 and CD23 were negative, ruling out the possibility of CLL or SLL. Then we did CD10 and BCL6. They are the germinal center markers, so ruling out the possibility of follicular lymphoma. Cyclin D1 was negative, so we ruled out mantle cell lymphoma. CD43 was diffusely positive. CD43 is a T cell marker, but when it comes in the same cell which were positive for CD20, they show that it is a BNHL, and around literature says 30 to 40% of marginal zone lymphoma shows CD43 positivity along with CD20 positive. We also did Ki67 labeling index, which was low in this case. So in summary, the tumor cells were positive for CD20, CD43 and Ki67 proliferation index was low. The tumor cells were negative for pancytokeratin, GATA3, CD3, CD5, CD23, CD10, BCL6, BCL2 and cyclin D1. So the diagnosis was extranodal marginal zone lymphoma of mucosa associated lymphoid tissue, urinary bladder. I congratulate sir to exactly picking up the diagnosis. A big round of applause for sir. We subsequently we received bone marrow biopsy which was adequate and showed hematopoietic cells of all three series, and there were no aggregates of lymphoid cells or lymphoma cells in this biopsy. It was free of lymphoma. So what is a marginal zone lymphoma? So they are the group of indolent B cell non-Hodgkin lymphoma which arise from marginal zone of lymphoid tissue. They are typically slow growing and can involve extranodal site, nodal sites and splenic sites. So this is a follicle, and these loose zones, large loose zone is the germinal center. They comprises of centrocytes and centroblasts, which are B cells. Along with that, there are some T helper cell and T regulatory cells. This compressed zone is the mantle zone, which are tightly packed B cells of primary follicle, which are pushed aside by germinal center. And this loose zone is the marginal zone, which is less packed and mix of memory B cells and naive B cells. So this tumor arises, marginal zone lymphoma arises from this side. So according to the 5th edition of WHO hematolymphoid tumor, they have classified marginal zone lymphoma as splenic marginal zone lymphoma, extranodal, nodal, and primary cutaneous marginal zone lymphoma and pediatric nodal marginal zone lymphomas. They all have overlapping histological and immunohistochemical features. However, they have different clinical features and distinct etiologies. 7% of all the mature non-Hodgkin lymphomas are marginal zone lymphomas. 9% of these marginal zone are splenic, 30% are nodal, and 61% are extranodal. So if we see the etiology, the etiology remain unknown for nodal marginal zone lymphoma, and their incidence increases with age. Splenic marginal zone lymphoma generally occurs in middle age to older adult. They have propensity to chronic infection such as hepatitis C infection and associated with autoimmune disorders. Clinical presentation in nodal marginal zone lymphoma is generalized lymphadenopathy, often in head and neck. They present with B symptoms like fever, night sweats, and weight loss. They may be asymptomatic also. In splenic marginal zone lymphoma, patients present with splenomegaly and symptoms related to cytopenia like anemia and thrombocytopenia. B symptoms are rare, and peripheral lymphadenopathy is uncommon in these lymphomas. Coming to extranodal marginal zone lymphomas, which we traditionally call as maltomas, the clinical symptoms are related to site related. For example, if lymphoma is gastric, then the symptoms are abdominal pain, heartburn, cough, shortness of breath, chest discomfort in pulmonary side, then proptosis, vision change in ocular side, and xerostomia and swelling of salivary gland in parotid side. The most common site involved in extranodal is stomach, followed by orbit, lung, parotid gland, skin, breast, colon, thyroid, and they all have different etiologies. Like in stomach, it is related to H. pylori, lung, Achromobacter xylooxidans, then ocular nexa, chlamydia, borrelia in skin, and Sjogren syndrome in salivary gland, and Hashimoto thyroiditis in thyroid. So coming to urinary bladder lymphoma, the bladder lymphoma generally present with hematuria, increased frequency, urinary obstruction, dysuria, or lower abdominal pain. Some patients are asymptomatic and they constitute less than 1% of all the genitourinary tumors. They arise from the lymphoid tissue as a result of chronic inflammatory process or immunological disorders. So if we see superficially the pathogenesis of extranodal marginal zone lymphoma, they start with chronic antigenic stimulation, for example, from different bacteria or autoimmune disorder, leading to persistent immune stimulation, which lead to proliferation of marginal zone B cells. It leads to various genetic abnormalities like translocation and mutation, and they activate various signaling pathways like NF-kappa beta pathway, and this leads to immune dysregulation, which leads to accumulation of genetic errors in B cells, and this allows abnormal B cell clones to evade apoptosis and they proliferate. And sometimes due to the mutations of TP53 and rearrangement in MYC gene, large cell transformation also occur. From pathology point of view and diagnostic point of view, the peripheral blood smear in splenic marginal zone lymphoma typically show lymphocytosis with villous projection in the lymphocytes. They are the characteristic finding in splenic marginal zone lymphomas. Peripheral smears in nodal marginal zone lymphoma are typically normal, and extranodal marginal zone lymphoma, peripheral blood involvement is absent. Bone marrow in splenic, they are commonly involved. They show nodular or interstitial or diffuse pattern of involvement. Paratrabecular aggregates or nodular aggregates are also seen in nodal marginal zone, and bone marrow involvement is quite rare in extranodal site. All the tumors have similar histopathology, which show small cells, small atypical lymphoid cells, and immunophenotype is also quite overlapping, like CD20 positive, and they are negative for cyclin D1, CD5, and CD23. Cytogenetic and molecular testing are also performed, which show overlapping mutations like Notch2 and KLF2 in splenic and nodal marginal zone lymphoma, and extranodal marginal zone lymphoma typically show different kind of mutation at different site like translocation 11-18 seen in gastric maltomas. They can also be staged according to Ann Arbor stage or Lugano staging. Ann Arbor stage is typically done for gastric maltomas, and Lugano staging is typically done for non-gastric maltomas, and it is according to extent of lymphoma involvement. So these are indolent lymphoma and with median survival of more than 10 in majority of the cases. First line of treatment focuses on eradicating of underlying infections. Radiation therapy is quite useful. Advanced or systemic disease, rituximab based regimes either alone or combined with chemotherapy can be used, and transformation to DLBCL regimes like R-CHOP can be used. Histologically, there is for gastric marginal zone lymphoma, there is GELA histological grading system, which is based on scoring of different histological parameters like lymphoid infiltrate, lymphoepithelial lesions, and stromal changes. Accordingly, we can score complete remission, probable minimal residual disease, responding residual disease, and no change. So according to this review article, lymphoma of the urinary bladder, they said that lymphoma of urinary bladder can be primary or secondary, and there is a female preponderance with middle-aged women. Secondary lymphoma of urinary bladder occurs in 10 to 25% of cases of leukemia and lymphoma of advanced stage systemic lymphomas, and according to them, less than 100 cases have been reported, most common being the maltomas. DLBCL may arise from the transformation of the malt lymphoma. Most common symptoms are hematuria, dysuria, urinary frequency, nocturia, and back pain. Typically exhibit translocation 11-18, and radiotherapy is the effective treatment of choice. So if we see that, we dig up some literature, this landmark paper by Coy, Freeman et al., they showed that occurrence and prognosis of extranodal lymphoma, and they mentioned that bladder lymphoma was first published in year 1885 by Ave and Chaffee in post-mortem cases of two patients. First definitive report of MART in urinary bladder was published by Kohara et al. They showed that 56-year-old Japanese housewife which had symptoms of cystitis presented with hematuria, and they said that primary lymphoma of bladder may be considered a lymphoma that originates from mucosa-associated lymphoid tissue. This series published by MD Anderson Institute, Cancer Institute, said that 59 patients, they had 59 patients with follow-up history. They said there was female preponderance with 57 of median age, and 77% of the patient had cystitis. And the most common pathogen involved was Listeria coli, and all the patients were treated with combination of radiotherapy, rituximab, antibiotics, and TURBT, and all were alive at the last follow-up. Another case from Tokyo, Japan, they published that 65-year-old female who presented with hematuria and had history of cystitis was again diagnosed as MART lymphoma, and it was treated with TURBT and radiotherapy, and there was the disease remained regressed after 2 years. A case report from China, 77-year-old female with frequency dysuria. She was treated with TURBT and was alive and healthy at 15-month follow-up. Another case from USA, 65-year-old female who presented with cystitis was diagnosed as mild lymphoma after TURBT, and they were treated with adjuvant RT. From Indian scenario, only one case was noted in which there was a 40-year male who presented with frequency and dysuria, and it was diagnosed as MART lymphoma, and it was treated by TURBT, radiotherapy, and R-CHOP regime. So in our case, patient was middle-aged patient, and patient had a long-standing history of urethral stricture with continuous intermittent self-catheterization. The possible pathogenesis in our case might be chronic antigenic stimulation, which led to cystitis and further led to MART lymphoma. So take-home message is extranodal marginal zone lymphoma of urinary bladder is rare, but it is important to recognize as early diagnosis through imaging, cystoscopy. Histopathology is crucial for effective treatment. Treatment options are localized, such as radiotherapy, rituximab with excellent outcomes, and vigilance for underlying chronic inflammation or infection should be done for guiding the management, and long-term follow-up is essential to monitor for recurrence or transformation. I invite sir for further comment on management of the patient.
Actually, even after we got the diagnosis and we were told very emphatically that this is B-cell lymphoma, we came across a case report that he has not shown where the patient was treated with antibiotics, diagnosed as B-cell lymphoma of the urinary bladder and treated with antibiotics and responded. Now, this young man, we had this thing in mind that we are dealing with a benign disease, it's a non-malignant, and finally, the pathology that we got was a malignant one. But we thought about it, and then we felt that we should refer him to medical oncology, but we'll keep him on follow-up and see how he responds to the first or the second cycle of chemotherapy. He was treated with chemotherapy from medical oncology, and he started responding well. And then he has completed his chemo, and following chemo, we have done his cystoscopy, and now his cystoscopy is normal. And radiological imaging wise also, the lesions have disappeared. And although his cystoscopy was done just about 4 weeks back, and further follow-up we are still awaiting, but he definitely responded to the chemotherapy, which we were scared whether if it is related to chronic infection by chemotherapy, there may be an aggravation of his problem. But the pathologist, Dr. Seema, was emphatic that this is lymphoma and you treat like lymphoma, and that is how this young man or middle-aged man was treated, and he has done well.
Majority of the lymphoma that you show there's some sort of trigger, like some sort of infection is there to cause this. In those cases, is there any evidence to find those infections in the histopathology specimen?
Not in histopathology, but we have to correlate with microbiology, culture reports.
And those organisms are never found in those issues.
It is difficult to isolate organisms in histopathology specimens.
And once it reaches the lymphoma stage, like in stomach that happens, so once they pause, they are not fine. They are not, and you will just have that tumor.
Since this is a localized disease, so the localized treatment should be considered over systemic treatment like chemotherapy.
Yes, sir. So there are several case reports. Yes, sir. There are several case reports in which they have mentioned that even the antibiotic works in these kind of malignancies, and they are saying that radiotherapy is the treatment of choice rather than dealing with yes, sir. With dealing with chemotherapy.
Radiotherapy has been
Was there any evidence, clinical or any laboratory evidence of a patient having infection, or which while that he was doing a self-catheterization for stricture treatment?
This would have been one self-catheterization if you consider something that will be contaminated. Contamination is very common, very common. Practically, most of the people go something or the other. So we diagnose that the patient has associated fever, or there is increase in frequency, dyspnea, and clinical features to suggest that there is more than
Catheter giving samples will always show that they are psychological.
Okay, we conclude this CPC. Thank you, Professor Atul. Sir, any final comments on the case? Sir, any final comments on the case?
I think we discussed all the aspects in this particular patient. For surgeons, we typically do not think so much. We operate and send the sample to our pathology colleagues. So, and then in retrospect, we sort of, if something unusual comes, then we start thinking, acha. Thank you so much. Thank you for the invitation. Thank you.
Only then we will